This conference will now be recorded.
Welcome to the class, people. So this class is about the basic of urodynamics and few questions about the part 2, and also one station teaching station for part 3. Okay, so basically for the interpretation, basic knowledge is necessary for the urodynamics because it comes both in part 2 and part 3 exam. Now, urodynamics, why it is done? It includes all measurement that assesses the function or dysfunction of lower urinary tract by appropriate method. It could be cystometry or pressure flow studies. Okay, what is the aim? Aim is we want to diagnose the pathology in lower urinary tract that help us to guide surgical treatment, and sometimes we also able to predict the problem that may happen after surgery. For example, a patient is going for incontinence surgery and the patient has got voiding dysfunction. Then if the urodynamics is done before, we will be able to know that. Okay, apart from this, sometime when the surgery is done in for incontinence and the patient already has like detusor overactivity, so it will get worsened after the surgery is done. So this is the basic aim of urodynamics. We want to diagnose the pathology clearly that causes lower urinary tract symptom before we can opt for surgical management. Now these are the indications. This you guys should remember because for like MRCOG with all these indications only, the urodynamics is done. So urge predominant mixed incontinence or a urinary incontinence where the diagnosis is not clear. Okay, second, if it is possibility of voiding dysfunction, or if anterior or apical prolapse is there, or if previous history of stress incontinence surgery. Basically, with this, our aim is to find out that if we go and proceed with the surgery, what will be the outcome, whether any new symptom will come. So I'm repeating it according to NICE indications for urodynamics: urge predominant mixed urinary incontinence or when the diagnosis is not clear. Second, when the symptoms of voiding dysfunction. Third, apical or anterior prolapse. Or fourth, when there is a previous history of SUI already. So only these are four indications according to NICE. Apart from this, what the NICE says, that multi-channel filling or voiding cystometry before primary surgery of SUI or SUI predominant incontinence is not required, because for SUI basically you have to do clinical diagnosis that will depend on the clinical history. And also when we ask the patient to cough, then we can examine elicitate the SUI. So it is not required in the clear diagnosed case of SUI according to the NICE guideline. Now, before a patient goes for the urodynamics, what are the prerequisites? First of all, is a complete, comprehensive clinical history, including the symptoms, whether the patient is having urgency, frequency, nocturia, incontinence, their duration, effect on quality of life, past medical surgery, like if any previous surgery has been done, or their obstetric history, or any neurological disease. Apart from this, whatever the medication they are taken, it should be noted, and before urodynamics test, it should ideally be discontinued. Otherwise, the medication who are affecting the urinary tract symptom, they will change the diagnosis, or like some of the symptoms will be not be able to get it. Now so clinical history is important, clinical examination is important. What is a clinical examination? That we already know: abdominal examination, pelvic examination. Why? We want to check for associated prolapse. Please, all of you, mute yourself. And we want to see for pelvic masses, any atrophy is there. Apart from this, any pelvic muscle, how is the quality, contractility, or basically urinary leakage on straining, that is a demonstrating SUI, or focused neurological examination. Completed voiding diary has to be there, and quality of life questionnaire and urine analysis. So minimum these are the prerequisite we should be complete when we are taking patient for urodynamics. Okay. Now, what is the urodynamic consist of? Uroflowmetry and the measurement of PVR. The second is the cystometry, that is a conventional urodynamics chart that we are studying. Ambulatory urodynamics, video cystometry, and urethral pressure measurements. Okay, so first come to the uroflowmetry. Uroflowmetry is a non-invasive test, and usually we want to do investigations for the voiding dysfunction. Now there are two ways it can be done: by like rotating disc or gravimetric flow meter. But in the clinically situations, a gravimetric cell flow meter is used in the clinical practice, and the flow meter usually measures the volume of urine voided, and flow rate calculation is done. So this is not that much important. So in this way the uroflowmetry will be done. So patient asked to void over the uroflow meter in a comfortable and private environment. Rate and pattern should be analyzed, and usually it will be the flow rate will be the urine like volume or mass of urine passed per unit time, or ml per second, and the graphic recording is done. So this way the graphic, this is the uroflowmetry curve. So you know what is the normal uroflowmetry curve? It is a bell shape. There would be a rapid upstroke, a curve with a continuous flow, and clear maximum flow rate. So this is the Q max. Q max is the maximum flow rate. Then it declines and end cleanly. So this is the uroflowmetry curve. That is the bell shape. Okay. It is important because when you are doing interpretation of your urodynamic charts, then it is important to know whether the uroflowmetry part has got bell shaped curve or not. If it is not, that means there is some voiding dysfunction is there. Okay, now this is again the similar example. So this is the like bell shaped curve, and this is the amount of urine that the patient has passed. This is the again the bell shaped curve. You can see this is the bell shaped curve, and this is the like voided volume of 250 ml. Okay, so this is the uroflowmetry part, that of the normal flow curve. Apart from this, now there would be some difficulties, or there could be some issues, possible causes. Like if you see this is the normal, but instead of normal, if you see this zigzag pattern, that means there is a bladder outflow obstruction. Okay, this is the bladder outflow obstruction. If you see this kind of pattern in the curve, there could be associated urethral obstruction, or there could be urethral stricture. If it is sharp like this way, it is sharp up and sharp down, then it is a possible diffuser overactivity. So this helps this way. Looking at the euroflow shapes, you'll be able to find out what are the, like what could be the baseline pathology. Now again it is a similar kind of thing. You can see that there is ideally it should be this bell shape, but instead of bell shape you are getting this kind of thing. So here the flow is continuous. Prolonged Q max, ideally it should be more than 25, and see the Q max is 7 only. And so why it has happened? Possibly there have the kinking of urethra that you usually happen in cystocele. So this kind of pattern you will find. Okay. Now another this is the normal, and we are getting this kind of like curves are getting. So it is very clear that the urine flow is getting intermittent. And why so? Because of the hypocontractile bladder is there, and voiding difficulty is there. So if this voiding difficulty is there, that means if the surgery is done for this patient, there would be episodes of retention. So this way Doing uroflowmetry, we are able to predict that okay, what can happen after the surgery. So this patient would have a more retention episodes. Okay, now like this is the uroflowmetry. Now prerequisites for cystometry. There are two tests, uroflowmetry and cystometry. For cystometry, there should be equipment check, there should be urine analysis, urine infection should not be there. Otherwise, they for the urodynamics, the catheter, they put catheter in the bladder, so there would be infection and risk of UTI. Subsequent risk of UTI after cystometry is 1 to 10%. Now what we have to see, now these are the few things that you should know. Reference level, when the urodynamics is done, transducers are put. So the reference height where they should put will be the upper edge of symphysis pubis. Okay, so this is the references. Zero pressure. When the urodynamic study started, all pressure has to be zeroed, and these are zero to the atmosphere. Then, reducer pressure, it should be zero at the start. Okay, it should be zeroed at the start, and when the urodynamics is started, that time reducer, vesical, and abdominal, all three pressure line will have same pressure. Okay, some test will appear, some fluctuations you will find in the line. This is when the patient talks or patient take breaths, so that would be the live test. Now you can so the when the so this is the when the urodynamic is started, so they will set zero. Okay, or they will set zero to abdominal and vesical line, and all catheters should be flushed out. Now, after that, the placement of catheter is done. So basically, we have to calculate three pressures. So for the vesical pressure, they will put catheter in the bladder. Okay, so this is the catheter that is going into the bladder. Okay, and apart from this, for the abdominal calculation of P abdomen, it will be either in the vagina or it will be in the rectum, and P detrusor is calculated by the machine and by doing like a subtraction from vesical abdominal pressure from the vesical pressure. So this is the placement of catheters. Now like the normal values, so of a p vesicle is 5 to 50 centimeters of water. Normal value for p abdomen is 5 to 50 centimeters of water. P detrusor is when we subtract p abdomen from the p vesicle, and the normal value will be 5 to 15 centimeters of water. Now, pre-detrusor, you have to remember this value because this help in doing the interpretation of your chart. So, during filling phase, detrusor pressure should not increase more than 15. If it is increasing more than 15, that means that is a detrusor overactivity. So, because of that, this value is important to you guys. Now, for the filling cystometry, usually the patient either can be seated or it can be in upright position. Bladder is filled with saline, warm to the body temperature, and physiological rate of usually of filling will be 50 to 100 mils per minute. And patient with a, if they have a detrusor activity, then sometime the bladder filling will be done at a slower rate, 10 ml per minute. Physiological filling, so what is a physiological filling? 1 to 2 ml per minute. Okay, now what you have to check for, international continent society recommends these three sensations. So this you have to like explain that. First sensation of feeling, FSF, when the patient feel that the bladder is no more longer empty. First desire to void, when the patient says that I have to go to toilet, but at appropriate time, they're not in any hurry. So usually strong desire to void is the maximum systometric capacity. Sometimes the patient may feel additional sensation of urgency, fear of leaking, pain, or any other symptom also. So these three things, when you do the interpretation, basically these three things you will find that is written over the chart. Okay. After that, we our aim is to find out whether the patient have stress incontinence, urge incontinence, or mixed incontinence. So basically we give them some stimulus, that is a provocations. So provocation is like it usually given when the bladder is at maximum cystometric capacity. And what kind of provocative measures maneuvers can be used? We can ask patient to cough, to heel bounce, to posture change like lying to standing, and running water or hand washing. So these are the provocative measures that are used to demonstrate the incontinence. Okay. And so voidings after that, the patient so this is the filling cystometry, where we are checking the pressures, we are filling the bladder, we are checking the pressure, and we are giving provocation maneuvers to the patient. After that will be the voiding cystometry, where the patient is left alone in the appropriate setting to complete voiding. Okay. And during that time they would measure total voided volume, detrusor pressure, that is a p dat max, how what is the flow pattern, and if there is any evidence of staining is there or not. After that the catheters are removed, and post void residual urine is usually measured. Okay. So this is the basic basic mechanism how the urodynamics is done. Okay. After that, these few values you have to remember, because that usually helps in answering your part 2 and part 3 questions. So first sensation the patient should have ideally in 150 to 200 mils. Strong desire is the bladder capacity, that will be 400 to 600 mils. Detrusor pressure while filling is less than 15 centimeters of water, that I explained previously also, that at the time of filling detrusor pressure should be less than 15. If you find detrusor pressure less than 15, then we are happy that there is no detrusor activities there. But when the patient is putting pressure at the time of passing urine or voiding, that time the detrusor pressure would increase, but it will be like 70 centimeters of water. A peak flow rate, the rate with which the patient passing urine is 20 to 40 mils per second. And time in which a patient completes one void will be 15 to 30 second. Total amount of voided volume is 220 to 320. It is these values are also helps you in doing the interpretation of the bladder diaries. And the residual volume normal should be less than 50 ml. Okay. So now basically we are doing it to know the incontinence. So what is the urodynamics SUI? The symptom of the patient will be a leak on coughing, sneezing, exertion. And on the urodynamics, if you are able to see rise in abdomen and the p vesicle pressure, and the patient is leaking, so this will be urodynamic stress incontinence. Okay. Now people are confused with the two terms, SUI and USI. So SUI is the term that is used when you clinically demonstrate that the patient has a leak on cuffing. Okay, that would be SUI. On the other side, when the you has been provided with the urodynamics, and in the urodynamic chart you are able to demonstrate SUI, then you will say the patient have urodynamic stress incontinence. So that will be USI. So these terms people use wrongly, and for part 3 it will not make that much of a difference. With part 2 people you will lose your marks. Okay. So urodynamic demonstrated SUI will be urodynamic SUI. Now this is they are measuring the pressure. You can see this is the vesicle, this is the volume infused, this is the vesicle pressure, this is the abdominal pressure, and this is the detrusor pressure. Rise in p vesicle and p abdomen. At the same time there is a leak. So this would be the urodynamic stress urinary incontinence. Now detrusor activity. Now there are detrusor like overactive bladder symptoms we already know: urgency, frequency, nocturia, and leak. Now if the we did the urodynamics, and if in the urodynamics if we are able to see contractions, then then your your answer would be do, that is the detrusor overactivity. But if there is a detrusor overactivity, that means rise in p detrusor and p vesicle and the leak is demonstrated, then you will say detrusor overactivity incontinence. So there are two terms. Okay, if you are able to demonstrate like incontinence during your urodynamic interpretation, so when only contraction do, when contraction along with leak, then the answer will be doi. Okay, so please be very careful for this word when you are putting answer for part 2 or doing teaching for part 3. So this is again detrusor overactivity. You can see people, this is the volume infused, this is a p vesicle rise, a p detrusor rise. So rise in vesicle and detrusor, but p abdomen, pressure in abdomen is fine, and the leak is there. So this will be doi. Okay, if you do urodynamics, it will be doi because we can see leak also. Now so this way you usually the this way usually you will find your charts. So now you can see usually they write the pressure also. So you can see the like this is abdomen pressure, black one is the abdomen pressure, p vesicle, this blue one is the vesicle pressure, and this red one is the detrusor pressure. Now when you cannot demonstrate any leak anywhere. Okay, and when they're asking the patient to cough, usually there is a rise in the p abdomen and rise in the p vesicle. So you can see rise in p abdomen and rise in p vesicle, but there is no leak. And if you see the detrusor activity, so this is a detrusor, and there is no activity in the detrusor also, and there is no leak. So this is the normal there is no demonstrate usi or doi, nothing is demonstrated. So this is the normal graph only. Now another ways this for this I have shown this picture. So you can see here that the all pressure are fine, but you can see here the peristalsis is here. So initially when they are putting catheter, sometimes there could be rectal peristalsis. So this will be the artifact. Okay, this will be the artifact. Apart from this, now whenever you do the interpretation for urodynamics chart, you have to divide the chart into three part. So this one third, first one third part, you have to check the whether the machine was calibrated and all pressure curves are starting from zero or not. Okay, first third before you start filling. Okay, this is the first one third of part where the urodynamics started. So you have to check your pressure lines, all should start from zero. Then there would be middle part will be the filling part, like this is the filling part of this urodynamics. And then there would be the voiding part. So this is the voiding part, you can see the voiding curve. Okay, this is the voiding phase. So one third, second third, and third part. So you have to kind of divide into three part to see. Now in this if we start with the first one third, all three pressure lines starting from zero, so machine is calibrated. Now this is the like the blue one is p vesicle, and red one is p abdomen, and green one is p detrusor. Okay, now you see here and a cg, you can see cg is the patient coughing. So this is the provocation during filling phase they are using. So here there is a pressure is patient is coughing. So rise in vesicle and abdomen, 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 and there is no leak, so there is no SUI. Now they will write the first desire. So here is the first desire at this part. So nearing 250 ml, the patient is getting first desire. Okay, here nearing here, the patient is getting first desire. So that is fine only. Apart from this, the maximum capacity here, the patient pass urine, maximum capacity of the bladder here it is 500. So this is 500, the patient is passing urine. Okay, this is also fine. So apart from this, when they are coughing or doing anything, now you see the detrusor pressure. This is the green color detrusor. This is the filling phase still here, and detrusor is completely calm. See the pressure of detrusor, no change. So there is no detrusor overactivity. So in this filling phase, we are not finding any SUI uh, uh, or any detrusor activity. No incontinence is there. Apart from this, this is the filling phase. At the filling phase, the pressure will start increase. Pressure, both all three pressure will increase, and you can see the filling uroflowmetry curve. Uroflowmetry, it is almost bell shaped only. Maybe patient stopped in between, because of that this kind of curve is coming, but is the it is the bell shaped curve, and you can see that there is no residual volume is there. So this is the normal cystogram. Okay, this way the interpretation of the cystogram you guys have to do. Okay, now someone has to tell me the diagnosis of this. One person will tell me the diagnosis of this.
I'm stress urinary incontinence.
Yes. Why?
Ma'am, while coughing, there is leak,
Yes.
but no change in the detrusor muscle.
Yes. Very good. Now see people, this is the P detrusor. Upper one is the P detrusor, green line, and this is the P vesicle, and this is the P abdomen. You see the first third of the graph, all three lines are starting from zero, so this is fine. This is the filling phase. This emojis are there. Can you see these emojis? These are denoting the what kind of the provocation is going on. So the patient is coughing, this is the cough emoji. And now you can see here the patient is asked to cough, increase in vesical and abdominal pressure, and there is a leak. Can you see this dot? So leak is there.
Dot.
So similarly you are finding here, similarly you are finding here. But if you see P detrusor creating no problem. Okay, so
Where is
it
the
is
leak, ma'am?
only, this is the leak. This is the leak.
Water dot.
Yes, yes, water drop.
Ma'am, but isn't
Sometimes,
isn't the leak supposed to be shown on the yellow line on the
yeah,
Q?
anything, anything could be there anywhere.
Okay,
You have to look for it. Sometimes they show a drop. Sometime they write a leak.
okay, ma'am.
Yeah, and this is from the International Incontinence Society PDF. I have taken this chart. Okay, and like P detrusor is, there is no problem. If you see the last part of it, uroflowmetry, it is clear bell shaped curve is there. Bell shaped curve is there. Now you see this. So this is the answer to this USI. You can see a leak there. You can see a leak there. So this is the USI. So this way, ideally the description for the chart to be done, divide that in a three part, speak about the three pressures, uh, speak about the Qmax, any provocation change, what are the pressure changes, when the patient has first sensation, when the patient has normal desire, when the patient has strong desire, when the patient have maximum capacity, how much the urine volume passed, and what is the interpretation. So these are whatever like they should you see there, you have to explain everything. Now someone to diagnose, any person.
Mixed, ma'am.
Why mixed?
All the pressures are raised, ma'am.
Tissues are overactivity, incontinence.
See this is the patient is coughing here.
Reducer
First of
overactivity.
reducer
Detrusor
overactivity, yes.
overactivity with incontinence.
Large
With
incontinence.
so this is DOI. This is DOI. Now see here. This is DOI. Actually, now here the patient is coughing. No, this is the first leak, and you can see that P abdomen there is no change and there is no leak. Only leak is there when the reducer and vesicle is rising. You see here the leak of reducer and this like a P cycle, uh, and there is a leak. Here the patient is again coughing. See this. So here the leak is there.
There is also leak, ma'am. So it's mix also.
This leak is creating a trouble. This leak.
Even the last one, ma'am, there also there's cough and leak.
So okay, here, but they put it that mainly they shown us as a reducer activity, but here if you see go according to the chart, the cycle and reducer pressure rising and there is a leak. So this is giving us SUI picture also, but all other except this one, all other leaks they are coming with rise in the like P vesicle, P vesicle and P reducer. Okay, so this is I again diagnose this.
Reducer overactivity.
Detrusor overactivity.
Reducer overactivity.
What about this?
This is
There
leak,
is
ma'am. This.
no leak on coughing, ma'am.
This is cough.
Mm-hmm.
But
Patient
no
is
leak, ma'am.
coughing.
No leak.
Leak is there.
This leak.
Urodynamic stress incontinence it is, ma'am.
It is
Ma'am, where
SUI.
is the leak, ma'am?
I wrote it leak here.
Oh, okay.
And detrusor pressure is normal, ma'am, here.
Here diffuser sharp rise is there, but if you see this is the diffuser pressure rising. This part of graph, if you see this is the diffuser pressure rising and leak is there. Okay, this is diffuser pressure and the cycle pressure both are rising and there is a leak. And if you see both pressure, all three pressure rising and leak, all three pressure rising and leak, and it is the no voided volume is fine. There is no problem. This is a bell shaped curve. Okay, so this is here. It is reducer overactivity. Here rise in reducer pressure and rise in vesicle pressure, and here on coughing, like here all three pressures are rising and the patient is coughing and there is a leak. So this is reducer overactivity and USI.
Detrusor incontinence.
But voiding patient compliance is normal and no evidence of voiding dysfunction. This curve you can see bell shape, so no voiding dysfunction. Okay, what is this?
Pressure detrusor. Detrusor rise. There is any leak? Nothing. No
Detrusor.
leak.
So all pressure is starting from zero. If you see this part of graph, this is the P
Correct.
cycle and this is P detrusor. Now, can you see the pressure 31? And ideally
Hmm.
pressure should be less than 15. So there is a rise in the pressure more than 15. Okay, but there is no leak. There is no leak. Can you see there is no leak? Fine. And if you see the uroflowmetry, you can see the patient has a bell shaped curve, but see the capacity of bladder is 333. The patient have got small capacity bladder.
Okay.
Okay, so patient has got a P reducer 31 in filling phase, no leak. First surge is very small, 150. Stronger is 333. Normal voiding without any residual volume. So this is detrusor overactivity. This is not incontinence. This is detrusor overactivity with uh, uh, normal voiding with small capacity bladder. So this is a complete interpretation. Okay, now diagnose this.
Leaks there with substrate incontinence is here. Outer phase
One leak is
Procedural
here.
involved.
is here.
One leak is here.
Yes, ma'am.
So this is on
No,
coughing and
first,
cycle and
yes.
pressure is rising.
Mixed
Now you see
Procedural.
stress
this
during
leak.
erectile incontinence.
This is the second leak
Second leak.
and rise in vesical pressure and rise in detrusor pressure. So
Mixed.
this is
SUI.
Mixed.
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 this
Mixed.
is
Mixed.
DOI. Yes, and this is SUI. So this is mixed. Now this is the answer to this. So filling phase, detrusor overactivity they saw. On provocation phase, SUI they saw. So the diagnosis is recluser incontinence, USI with large leak, normal capacity bladder. Okay, this is the report of this. So you have to kind of divide the chart into three parts, and you have to see leaks and reducer pressure carefully. Otherwise, you would miss. Okay, what is this?
Severe art. Severe art. Capacity. First are
What?
severe.
Where is the reducer? Reducer is this one.
Yes,
Can you
ma'am.
see? Can you see any rise in reducer pressure?
Ma'am, it
Any
is.
any rise is there?
No, it is like voiding
No.
process.
In voiding, it is rising.
No,
The
voiding it will
first
rise.
one, city with sensory.
So what is this? What is this chart?
Inflammatory, ma'am, only, not voiding.
Where is the
Small
leak, ma'am?
capacity bladder.
Sensory.
Yes, sensory urgency. So first sensation is of 66 ml. First feeling comes as 66. First urge comes as 80. Severe urge, it comes
105.
as 50. Capacity is 346 and there is no detrusor contraction. So this is sensory urgency. So International Continent Society defined urgency as a strong desire of void accompanied by fear of leak or fear of pain. There are two types of detrusor dysfunction: urgency with overactive dysfunction, where the patient have urgency and detrusor contraction. That would be motor urgency. Another kind of urgency where the patient have hypersensitivity and sense, that would be sensory urgency. So in sensory urgency, patient would have constant desire to void urine that will never be satisfied by passing urine, and like on if you do the urodynamics, there will be no reducer contraction. Apart from this, the patient will have, this is because of the detussor hypersensitivity. So this is the difference about detussor overactivity and sensory urgency. It is very important to know, because part 3 people, you have got one viva where the patient has got sensory urgency. So how to identify? So this way you will be able to identify sensory urgency. Is it clear?
Yes, ma'am.
Yes, ma'am.
Yes, yes.
Okay, some urodynamic artifacts are also there. So like sometime you will find all of the pressure finding suddenly. uh, it can happen that the catheter gets expelled. All of a sudden you will see the pressure lines are for, like they have come parallel, no activity. That means the catheter has fallen down. Sometime you will find this kind of oscillations. Can you see this? This is a tube running tube. The tubes, these are the pump vibration. Okay, so because the tubings are touching together, there could be many kind of artifacts, but I'm not showing because that is not necessary for you. Another one is a video cystometry. Video cystometry is done when the contrast is filled. Basically they help us to find out the bladder shape, vesicurectory reflex, bladder neck mobility, and urethral function during voiding. This way the video cystometry is done. So you can see again the pressure, P detrusor, P vesicle, and P abdomen, and you will be able to demonstrate leak on the whatever the way they do it. So here you on the fluoroscopy, here you can see rise in P detrusor, rise in P vesicle, and leak is there. So this is that detrusor overactivity. Oh, sorry, it should be detrusor over DOI, because the leak is also there. So answer would be DOI in this.
Ma'am, where is the leak?
Leak is coming here. Yeah, this one.
In the picture. We will.
Yes, this is the video
Okay.
cystometry. They are
Yes,
doing
ma'am. Okay.
fluoroscopy. They are doing fluoroscopy. Yes, just you should have an idea about that. What is video cystometry? Another one is ambulatory urodynamics, in which like many patients, they are very shy for bladder filling and to void. So the machine is calculating everything. So for those kind of patients, ambulatory urodynamics, so it will be like instrument will be put like that, and the bladder function will be noted naturally, but this will take very long time. Urethral pressure flowmetry. So why it is important? Urethral pressure flowmetry. So maximum closure pressure of the urethra, if it is less than 25, that means the sphincter is weak. So weak sphincter deficiency. But if the pressure is high, that means the urethral hypermobility, because the urethral support is there instead of weak sphincter. So why it is important? Like if you are doing surgery for SUI, if the patient has a sphincter deficiency, then doing surgery will not help. But if the patient has got stress incontinence because of urethral hypermobility, that means the pressure is fine, urethral pressure is fine. That time the surgery for incontinence will be successful. Okay, so that much is the value. Now bladder diary, in the bladder diary, they note the frequency, and daytime frequency more than 8 and nighttime more than 1 is considered abnormal. If the patient is passing a small amount of urine, that means detrusor overactivity is there. And if the patient is passing larger amount of urine, that there could be polyuria. It could be in the diabetes mellitus. Apart from this, in the diaries leaking episodes, any pad change, and time and volume of fluid intake, it should be noted. Okay, So this is the example of a bladder diary. So this is day 1, this is day 2, and this is day 3. Okay. So from you can just calculate amount input of one day, you can calculate output of one day, and you can also calculate the frequency. So this is the daytime frequency. So so 8 times she is passing in a day. So she is having daytime frequency. She is waking up at night. So she has nocturia also. So daytime frequency is there, nocturia is there, and if you see the volume of leak episodes are there. Now she's ideally the amount of urine to be passed in one void should be 220 to 320, but she's passing 100 ml, 50 ml, 50 ml, 200 ml. So she has got small capacity bladder. So from the bladder diary, you can calculate total fluid intake, fluid output, um, uh, uh, in, uh, input, whether it is low and high, daytime frequency, nighttime frequency, leaks, and amount of urine. If it is passed, it is small or it is adequate. Okay, bladder diary is also important because you need to know. Sometimes they give you bladder diary also in the exam. Now, some very less question. So, 50-year-old woman, I would require one volunteer for part 3 going in November. So, 50-year-old woman with urinary urgency frequency more than 10 times, 2 3 times at night. She has no urge or stress incontinence. This is her filling cystometry. So, what is the diagnosis?
System.
Diffuse overactivity.
Diffuse overactivity.
Sensitivity.
So activity.
Yes.
Detrusor
This
Diffuser
is
overactivity.
P cycle, and this is P detrusor. Can you see and rise in the pressure? Now this is again urodynamics, video urodynamics picture. The patient have leak on cough, urgency more than 6 to 8 times, 2 3 times at night. Urodynamics video urodynamic trace is shown. What is the answer? This is P abdomen, this is vesicle, and this is detrusor. There are
Urodynamic stress urinary incontinence.
yes, P abdomen and P vesicle both are rising, so it is USI.
Ma'am, why
Ma'am,
is the
P
leak?
cycle is not rising.
Yes, what you are saying? P detrusor is this, P
P
vesicle is blue, and P
oh,
abdomen is black, and this is
okay,
the
okay,
Yeah.
leak. This is the leak.
Okay. This is
okay,
the
okay.
this black one is the leak. Okay.
Yes. This is fluoroscopy.
Mm-hmm.
Okay. In the uroflowmetry, the patient has got this type of curve. What do you think? What could be the answer?
Bladder outlet.
Strict stricture.
Stricture, stricture.
Outlet obstruction.
Kinking, urethral kinking, cystocele. Okay. I have put the answer already instead of question. Okay, a 55-year-old woman. She has SUI. She completing mid urethral tape procedure. Request investigation because she is concerned whether it will fail or not. What investigation will give them more information on prognosis? You have to
Urodynamics, ma'am.
Urethral pressure profilometry.
urethral pressure profilometry. I just showed the picture that if it is more than 5, that means the sphincter is strong. If it is less than 25, more than 25, sphincter is strong. Less than 25, sphincter is weak. If sphincter is weak, surgery will not be of any help. Okay, so urethral pressure studies that will give the answer.
Ma'am, could you please repeat once again?
I'll show
If it
you
is
the. I'll show you this again. Now you have to see this. So this is the urethral pressure profilometry. Basically, we want to know whether the sphincter is weak or not. if it is less than 25 pressure, urethral closure pressure, that means sphincter is weak. If the sphincter is weak, going for a tape surgery will not help. But if the leak is there and the sphincter has like pressure of urethra is more than 25, that means it is because of hypermobility. In this condition, it um,
It will work.
pressure, if the surgery is done, outcome would be good.
Okay.
Okay.
So urethral profilometry. Urethral
Yes.
pressure profilometry.
50-year-old woman with a mixed incontinence has got urodynamics after failed pelvic floor muscle training and trial of anticholinergic. So what indicates USI?
USI.
D.
Rise in the
D.
pressure abdomen, rise in the pressure vesicle, but no change in the pressure detrusor.
Death.
D,
And
ma'am.
this is there.
Sharp rise in PVS and P.
Rise in abdomen and
Sharp
vesicle and P detrusor.
abdomen vesicle rises without
With
any rise in
leakage.
PDET, and there is no
Yes.
Leakage.
and there's leakage. Yeah.
Okay, so I would like one person who can do the one stage, one person who is going for part 3 exam, November.
I can do, ma'am.
Your name?
Nadi, ma'am.
Okay. Read that there are two papers to read.
Next slide, ma'am. Previous slide, ma'am. Okay, ma'am.
Want to start? Should I set the timer?
Yes, ma'am.
Start.
Hi, I'm Lutfamin. You are?
I'm William Estevan.
Hi, William. How are you doing?
I'm good. I'm good.
Mm-hmm. So, are you enjoying your work?
Yeah, yeah.
I can see you want to learn about urodynamic graph. Is that so?
Yeah, yeah, yes. Actually, I attended the Urogynec clinic with the
Mm-hmm.
consultant. Like patient was saying something, and he was giving some management, and the urodynamics graph is. So I'm not aware actually what is a diagnosis, how to do interpretation, what is a management plan for the patient, and what should I
Okay,
ask her.
William. Okay, William. Urodynamic graph, it's a really good topic to discuss. So today we will discuss about what is urodynamic and how can we read this urodynamic graph. But to whom patients we will, what is the indications for the urodynamic test and how is the management plan? Is that okay?
Mm-hmm.
After the discussion also, I will give you some reading materials and you can go through some videos and graphs are there. We can discuss also. And also I will take the feedback from you.
Mm-hmm.
Okay. So, William, may I know what is your ideas about the like urodynamics? Why we do this?
Yeah, to diagnose the lower urinary tract symptoms.
Mm-hmm. Yes, you are absolutely right. When a patient comes with complaints of incontinence, before going for any treatment, we have to see what is the exact diagnosis. So basically, the indications are when patient had mixed incontinence, and what is the predominant symptoms we have to find out. Or any woman who had a history of previous surgery for the stress incontinence, but it was failed, then also we have to see this urodynamic. We have to do this urodynamics, and also if any woman has voiding dysfunctions and any anterior compartment prolapse, then we will do this urodynamic testing. And the fourth one is we have to know after the surgery what could be the patient's further complaints. To know about that, then also we can do the urodynamics. So can you tell me like one of the indications when we do this?
Yeah, when the diagnosis is not clear, possibility of mixed incontinence or voiding dysfunction.
Yes, you're absolutely right. So first of all, when a patient come in the outpatient department, we have to ask a detailed history regarding her presenting complaints, like how many times she's facing these problems, and whether she coughs during whether she leaks during coughing or sneezing or doing any heavy exercise. Then we have to ask whether she needs to go to rush to toilet, or before rushing to toilet whether she uh, wet herself. Then we have to ask how many times she go to toilet in the day and morning time. Are you following me?
Mm-hmm. Yeah, she's
Also
going
we have
five
to
six
ask.
times in a day and one two
Mhm,
times in a night, and she would leave coughing.
mhm. So going in the daytime, if it is like more than 8, and in the night time if it is more than 1, then we can say she has frequency. Okay. And as she has cough when she has leak when she coughs. So see, she has symptoms of nocturia. When patient come we go to toilet more than one time at night, then it is we call this nocturia. Then we have to ask her whether she has any other symptoms like any bulge, to rule out any cystocele or voiding dysfunctions. Then we have to take a detailed history about her fluid intake, like what kind of fluid she is taking, whether we have to take about whether she is taking any medicines like that can cause this like diuresis, whether she has any diabetes. Are you following me?
Mm-hmm.
Then we have to ask like what is her obstetrical histories, like how many deliveries she had, because sometimes multiple deliveries can loosen the weaken the pelvic floor muscles. At that time also patient might have incontinence. Also whether she has any previous surgeries, and whether she has any chronic disease like chronic cough, chronic constipations. These things we have to ask for. Also her BMI and what she is doing, like well long standing, whether she is doing any extra work, that long standing heavy exercise or janitor, this kind of work, then might have these situations. So can you tell me like what do you get?
Yeah, so we need to check for the frequency, urgency. We need to check for the voiding and post voiding dysfunction symptoms.
Mm-hmm.
We need to look
Yes.
for the risk factors also.
Mm-hmm. So yes, you're right. Then we have to do the examination of the patient. So we will ask the patient to uh, we have to take the permission from the patient, and with the in the presence of chaperone we will do the examination. We will ask the patient to cough to see whether she is leaking or not, and we will ask whether she is following any. We will give her a bladder diary. It includes her leisure time and also her regular working time. And we 3 days bladder diary, with 3 days bladder diary she will come. So the patient you say saw in the outpatient, did she had this bladder diary?
I didn't look for.
Mhm. So we have to see, like in the bladder diary, we will say, see how many. We have to ask the patient like how many times she take the fluid, what kind of fluid she has taken, and when she went to toilet, and whether she leaked any time. She has to note down, and she with 3 days bladder diary, she will come to us. Then we can also find some clues from there. So the patient you saw in the outpatient department, consultant finds some positive findings. So she referred her for the urodynamic testing. So this is the so urodynamic testing. It's basically we can do in the outpatient department, where we have to create the micturition cycle. We will see the voiding function and storage function of the bladder and the urethra. Are you following me?
Mm-hmm.
So first of all, we have to address the patient, and we have to ask the patient when she feel comfortable, feel the bladder, she will void in a transducer. So it will give us the information about the urethral function, that is uroflowmetry. And then we will empty catheter the patient. Before doing this procedure, we have to rule out whether the patient has any latex allergy or not, because we are using the catheter here. So then we will catheter the patient, and we will do put two transducer, one in the bladder and one in the rectum, to see the bladder pressure and the abdominal pressure. Are you following me?
Mm-hmm.
Oh, yes. Then we will fill the bladder, and we will ask the patient to cough. And when she gets her first desire, we will note it down. Then the strong desire and the maximum desire. Then she will empty the bladder. So whole the scenario will be graph, and we will find a graph like this. So you, as we can see now, here is the graph. So the first line, it is for the pressure. You can see it is the pressure detrusor, the green one, and the second one was pressure vesicle, and the third one was pressure abdomen. Okay, and here you see the bladder is filling. So when she get the first desire, we have to find out. And when patient was cough, this is the emoji for the cough, and there is some leak. You see, a drop is there. With coughing, some drop is there. You see, are you getting me?
Yes, yes.
So if patient coughs with leaks with cough, call this stress urinary incontinence. So what do you think? What is the graph for? See here, the patient is coughing and there is a leak, and there is no change in the detrusor muscle pressure. So what
Okay.
do you think? What will be the graph? It is stress urinary incontinence, urodynamic stress urinary incontinence. Okay.
Okay. Yeah.
And see the uroflowmetry, when she divide, there is no it is a simple see a good bell shaped curve is there, so it is her voiding function is okay. So this is a plain stress urinary incontinence. So are you like, do you understand what I want to tell you?
Yes, yes.
Yes. So what do you anything want to know?
Time finish.
Thank you for your time.
Okay. So how you did?
Ma'am, you tell me, I don't know.
Good. But see, there were three part of the question. Ex- uh,
Okay, management plan.
point in history taking, you have to explain him. You have to explain the chart, and you have to explain the management part. So you did fine only, but information when you were explaining history taking to this role player, you took nearing 6 minutes. Because of that
Mhm.
management plan, you were not able to explain to the student. On the contrary,
Yes.
this kind of station in history taking, you have to spend least time, because more
Mm-hmm.
marks will be on explanation of chart and management.
Okay, ma'am.
Okay. So
Yeah, I forgot about the management. Was there?
yes, because of that, this reading of question, what they want you to do in 10 minutes is very very
Mm-hmm.
important.
Ma'am, I have a question. So,
Hmm.
when we will do this station, this type of station, should
Hmm.
we need to say how we will do the urodynamic, like ask to patient void these things? Then
A
sometimes
little.
could be.
Yeah, see, urodynamic part you have to explain, history taking part you have to a little fasten, and you ask to the role player directly, do you want me to do only interpretation, or do you want me to explain how it is done? So whatever the role player
Okay.
says, according to that you have to answer. He will guide you.
Okay.
He will guide you.
Mm-hmm.
Like, if I change the question and remove the management plan, then you get complete 10 out of 10 marks. But because of this management, one third of the part is not done, so your marks will
Yes,
be cut.
ma'am. Yeah, ma'am.
Okay.
Mm-hmm.
So basic guide is what to
Got the
everyone knows
history.
urodynamics. Everyone knows urodynamics, but the person who is organized, who is reading the question well, what they want in 10 minutes, and if you're not able to understand, take hint from the role player. What you want me to explain?
Mm-hmm.
What you want me to explain? That will help you
Got it.
so that their tick box marks for, ticks will be done. Then you get the marks. Okay.
Mm-hmm.
Yeah, this station is
Okay.
coming last 2 3 exams.
Yeah. I saw there was management, but I forgot later.
Hmm. Okay, not an issue. So it's a learning.
Thank you, ma'am, giving me the chance.
Okay, welcome. So coming to answer, what you have to say. Hello, William. How are you doing today? I can see that you attended a patient with a consultant in the urology clinic, isn't it? Yeah, very nice. And you came here to know about the management of the patient and also about the interpretation of the chart. Is this so? Wonderful topic you have chosen. Have you got any background knowledge about that? And why you really want to learn it? Though I appreciate your effort that you come here. So in today's session, I'll just explain you how to take what points we have to put in the history, how to explain the trace, and what will be the management plan. If I'm not clear at any stage, you can stop me. Okay, how that sounds to you, William? Okay, now you have seen a patient, isn't it? So we if the patient is coming to the urology clinics and we have done the urodynamics, so we have to take the history, like her symptoms, whether she's having storage symptoms like urgent frequency nocturia or any incontinence or leak is there. Have you asked that? Any trouble while passing urine, voiding, or any post voiding symptoms? So this way we'll get a clue about it, isn't it? We need to take the history. What could be the associated risk factor, like whether the patient has got chronic cough, asthma, constipation, difficult childbirth, or what is her BMI, isn't it? So these are the few things we need to gather in the history. So in the exam he will give you some history. History points will be given, something he will say. Then in terms of coming to the urodynamics, so let me tell you the urodynamics is a basic is an specialized investigation that is done to diagnose the symptoms for the lower urinary tract. Okay, now when we do the interpretation, it has got like filling phase and the voiding phase. So this part is the filling phase, William, and this is the voiding phase. Okay, now coming to the interpretation of the filling phase, we can do this is the initial part of it. So first one third part. So in first one third part we see the pressures. So all pressures line should start from zero. That means our machine is calibrated, isn't it? So apart from this, there are three pressure lines are there. Can you see the three pressure lines? So can you see the P detrusor here? That means it is the measurement of P detrusor, pressure in detrusor. Can you see this line, blue line here? Can you see this here? This is the P vesicle. So this is the vesicle pressure. And can you see this red P abdomen? So you have to show each and everything. This is the P abdomen. This is the your abdominal pressure. So actually for P vesicle pressure, we put a catheter with a transducer into the bladder, and for P abdomen we put this in the rectum or we put in the vagina, and P detrusor will be calculated by the machine itself, that we get by subtracting P abdomen from P vesicle. So can you tell me how the calculation of P detrusor is done? Very nice, wonderful job you are doing. Now after that, now can you see here can you see this? So here the filling is there. Can you see here the normal saline is getting filled, isn't it? Now can you see it here this is the pump is like they are filling 100 ml per minute. Okay, now can you see the first sensation? Can you note it here? So patient has got a first sensation as 243. Okay, when the patient first feels the bladder is not full, can you see the normal desire? So the patient has a normal desire at 403. Can you see the strong desire? Patient has a strong desire at 246. To 426. So we have to find out the full sensation and the normal desire and the strong desire, isn't it? Then so this is all about the filling. Now, coming to the interpretation of this chart. Now, can you see these emojis? These are the provocations that we ask the patient to do. The patient is coughing. Can you see the cough is there and the leak? So, can you see the pressure changes? So, rise in P cycle and rise in pressure abdomen, but the reducer there is no change. So, this is a urodynamic demonstrated stress incontinence. So, diagnosis is urinary stress in urodynamic stress incontinence. Is it clear, William? Now come it here. So here the pump off is done, and with the maximum capacity, and the patient is again asked to cough. Then there is a rise in both vesicle and the abdominal pressure, and there is a leak. So this is the USI. So we do have a filling phase shows patient has urodynamic stress incontinence. Can you see the last part of it? Can you see the voiding phase, phase? It is a bell-shaped curve, and there is no residual volume, and the patient has got 625 ml of urine. Okay, so so our diagnosis will be urinary stress incontinence. Now you want to know about the management plan. For this management, first of all, it will be the lifestyle modification will be according to the risk factor we get in the history, that include like smoking cessation, or BMI reduction. Apart from this, the most important will be with the pelvic floor muscle exercises. So that will explain to the patient by the physiotherapist 8 contractions 3 times a day. If it is done, usually for 12 weeks, the visible effects would be there. After that, there would be the surgical. So first will be the lifestyle. After that, there would be the surgical management. Usually these days we are doing colpo suspension and also sling surgeries. And the patient, if they are not don't want to go ahead with any kind of surgery, then consideration for urethral debulking agents and some like medical management will be duloxetine. So these are according to the patient's symptom and what the patient is responding. So these kind of management can be done to the patient, isn't it? So can you tell me what will be the first line of management? Yeah, very nice. Any other concern question you have? So I found that you two were very enthusiastic learner. I'm going to give you certain handouts for the urodynamics, some video tutorials also. Go through that. If you have got any issue, you can come back, enjoy, have a lovely day. Thank you for time. So this way it has to be done. Anyone, any question? Anyone, any question?
Ma'am, thank
No, ma'am.
you.
Okay, welcome people. All the best
Thank you,
for your
ma'am.
upcoming exams. Bye.
Thank you.
Thank you so much, ma'am.
Bye.
That's a wonderful
Thank you, ma'am.
discussion. God bless you.
Thank you, ma'am.
Thank you so much.
Welcome.